The ache for a child is not just in the womb, it's in the mind, in the heart, and in the home. Infertility is often spoken of in hushed tones, confined to private grief and silence endurance. Yet beneath the surface lays a storm of entangled emotions, unseen depression, quiet anxiety, and the strain that presses even the strongest relationship. In this session today, we try to break that silence. We will journey into the emotional terrain of infertility, where hormones meet heartbreak and diagnosis collides with deep-seated desires. Entangled Emotions invites us to explore the lived realities behind lab results across through scientific research into the multidisciplinary lens that honors the mind, the body, and the soul. To begin this conversation, we'll be honored to welcome a leading voice in mental health. So first of all, we'll have a presentation by Juliet Janisha, who will be taking us through a study that she did. Dr. Juliet Janisha is a consultant psychiatrist at Chiromo Hospital Group, seasoned clinician and mental health advocate, as well as a medical educator. She's known for her strategic leadership and her passion for maternal health and ADHD. Dr. Janisha brings deep insights, research experience, and human-centered approach into today's conversation. I will be your host for today, Zawadi Kimari. And with this, I would like to invite Dr. Juliet to take us through the presentation for today.
Thank you so much, Zawadi. Good morning, everyone. Once again, my name is Dr. Juliet, a psychiatrist at Chiromo Hospital. It's a great honor to share with all of you the findings of my master's dissertation today, a work very close to my heart and was recently published in the East African Medical Journal. So the title for today's grand round is Untold Battles of the Heart, Mental Health and Quality of Life in Kenyan Infertile Couples. So this slide begins with a very symbolic image that merges both emotion and science. So what do you see when you look at this image? At first glance, we can see a couple cradling an orb containing a baby, embracing the hope of parenthood. And in the background, a closer look reveals ova and test tubes. These aren't just aesthetic choices, they reflect the promise of assisted reproductive technology. So this visual metaphor represents both the scientific progress and the emotional hope that science can indeed offer solutions. For many couples, the journey to parenthood today passes through clinics, lab rooms, and procedures like in vitro fertilization. But while science may help create life, it does not erase the psychological weight of the journey. My goal today is to walk through what we discovered in our study, the psychological burden that infertility carries, how it affects both men and women differently, and why mental health must become a central part of fertility care in Kenya and beyond. So let's begin. Next slide, please. So first of all, I begin with the definition of infertility. What is infertility? Infertility is defined as the failure to achieve pregnancy after 12 months of regular and protected sex. Why infertility is more than a diagnosis? Infertility is ranked by the World Health Organization as the 5th global disability, affecting 8 to 12% of couples worldwide. That's up to 80 million people. Prevalence is high in sub-Saharan Africa, with 1 in 4 couples affected. Infertility is linked to significant psychological distress and impacts quality of life, and is often overlooked in reproductive health conversations. In Kenya, there is limited data on the mental health burden among infertile couples. So what we wanted to know in this study, the aim of the study was to One, determine the prevalence of depression and anxiety among couples attending infertility clinic at a tertiary facility in Kenya. Two, quality of life of the couples attending the infertility clinic. And three, the association between depression, anxiety, and quality of life amongst couples attending the infertility clinic. Onto the methodology, a cross-sectional design was employed, recruiting 42 infertile couples, that's 84 participants, through consecutive sampling at Kenyatta National Hospital Infertility Clinic. A researcher designed a socio-demographic and clinical characteristics questionnaire was used to obtain the information on socio-demographic and clinical characteristics of participants. Beck's Depression Inventory 2 and Beck's Anxiety Inventory was used to measure the severity of depression and anxiety, respectively, and the World Health Organization Quality of Life Questionnaire was used to measure the quality of life of the participants. Onto the data analysis, we used SPSS version 25 and Stata for analysis. T-tests was used for gender differences in depression and anxiety, pairwise correlation for relationships between depression, anxiety, and quality of life, multivariate regression to control for confounders, and results were presented via graphs, tables, and narrative, and we put a statistical significance set at p less than 0.05. So moving on to my findings, this graph shows the prevalence of depression and anxiety in both male and females attending the clinic. So the prevalence of depression among males was 26.2% and females 57.3%, with the prevalence of depression among all the study participants at 42%. T-tests results showing that depression was significantly severe among females, and the prevalence of anxiety among males was 19% and females 42.9%. Zawadi, kindly just the other slide. 42%. So this is the distribution of anxiety level among the study participants. 69% of the study participants were normal. 13% had mild anxiety. 13% also had moderate anxiety, while 5% had severe anxiety. Now this figure shows the distribution of quality of life among the study participants. Majority, that's 35% of the respondents, describe their quality of life as average, that is marked in orange. Then 32% as good, 23% as poor, and 10% as high. So I used the WHO questionnaire for quality of life, and this usually assesses the quality of life in 4 broad domains: the physical health domain, psychological health domain, social relationships domain, and environmental domain. So the participants recorded the highest mean score in the physical domain, while environmental domain had the lowest mean scores. So what does that mean? This means that infertile couples perceive their physical well-being to be relatively good despite their infertility, while the couples felt least supported or satisfied in the external or environmental factors such as financial resources, access to healthcare, safety, the home environment, and social services. Now, here it shows the correlation of depression, anxiety, and different domains of quality of life. This table shows a significant negative correlation between anxiety and all the 4 domains of quality of life. Likewise, there's a significant negative correlation between depression and all the domains of quality of life. So the results indicate that increased depression and anxiety significantly lowers the quality of life in all the four areas. So depression, the invisible weight, as I mentioned earlier, the prevalence of depression was found to be 42% with a significant gender disparity. These findings align with existing literature, indicating a higher vulnerability of women to psychological distress. Why would this be so? There is, of course, a lot of societal expectations and stereotypes surrounding women's role in childbearing and the cultural emphasis on fertility. So it is essential to recognize and address the societal pressures that can exacerbate the emotional impact of infertility on women. Next slide, please. So on the anxiety, the prevalence of anxiety was 31%, again, with females experiencing a significantly higher rate, that's of 42.9% compared to their male counterparts. This echoes the broader trend observed in infertility studies, where women consistently report higher levels of anxiety compared to men. A study done in Iran by Maraufizad et al. Established that females were 2.3 times more prone to experiencing symptoms of anxiety compared to males. The emotional impact and societal pressures may contribute to heightened anxiety levels among women. This suggests a need for targeted interventions and support mechanisms to address the specific emotional needs of women navigating infertility. Now, depression and anxiety in men, even though the prevalence of depression and anxiety is lower in men as compared to the females in this study, it's crucial to acknowledge the mental health challenges that men experiencing infertility may still face. The prevalence of depression in men was 26.2% and anxiety 19%. This challenges the myth that men are unaffected. Stigma around male emotional vulnerability suppress help-seeking behaviors. In contrast to a study done by Yang et al. In 2017 in China, depression and anxiety in men were 21% and 8% respectively. Could be higher in our context as there are more societal expectations surrounding masculinity, which may include traditional notions of fatherhood and procreation, which could contribute to the psychological distress. And also the cultural emphasis on fertility might create a sense of inadequacy or pressure, impacting the men's mental well-being. So again, there's need for targeted support and interventions for both the genders. Quality of life amid infertility. The quality of life was mostly average, that's 35%, or poor, 23%, highest in the physical and lowest in the environmental domain, which was similarly observed in a study done in Egypt, 2020. The female, gender, and rural residents significantly predicted quality of life. This was also consistent with findings in Kenya as well as in Sudan. Linking depression, anxiety, and quality of life. Infertility creates emotional, social, and economic pressures, influencing perceived quality of life. As mentioned before, there was a significant negative correlation between anxiety, depression, and quality of life. That is, heightened anxiety and depression levels were associated with a decline in perceived quality of life. So mental health disorders notably reduce overall well-being in individuals experiencing infertility. So what these numbers tell us, rather our learning points here, there's mutual reinforcement of distress. The data shows that depression, anxiety, and reduced quality of life are closely interlinked. One doesn't just coexist with the other, they also amplify each other. There's also need for comprehensive mental health interventions across both the genders. Women bear more psychological strain across all the domain. This reflects the cultural pressure to bear children, internalized blame, gender-based stigma, and societal expectation. And even when the man is the one that has the cause or the difficulties of infertility, women still tend to bear the strain. Quality of life is notably reduced, particularly for women and those living in rural areas. Partner support and psychosocial care are underutilized. Despite the shared nature of infertility, many couples do not access support together. Men often hide their emotional distress, and women often carry the emotional load alone. So I conclude by a call to action. Mental health screening in fertility clinics is rare. Integrated, couple-centered reproductive care is essential. Ethical care must include emotional support. Research supports holistic gender-based interventions. And I close by saying fertility treatment must include emotional support, not as an afterthought, but as a core component of care.
Thank you very much, Dr. Janisha, once again for your remarkable research and sharing your findings with us. We must admit that a lot of very, very important insights have been shared to us this morning through that particular study. But just to bring it home and try to contextualize the realities around infertility, we have with us Dr. Charles Muteshi, who is a reproductive endocrinologist and fertility expert based at the Aga Khan Hospital. He comes with advanced knowledge on this particular subject matter, with an advanced fellowship from Oxford and a career devoted to reproductive medicine. Dr. Muteshi brings high levels of clinical expertise with a keen understanding of personal and societal complexities around infertility. So it is with these very, very many remarks, but a very summarized version of your extensive work that I'd like to invite Dr. Muteshi to help us just bring all of this information home to us. Dr. Charles?
Hi, Zawadi. Thank you for the introduction. And hello, everybody. Yes, so I think I will just maybe make a brief comment, Zawadi, before you go into the deeper discussion. I think the subject of mental health in subfertility or infertility has only become relevant or to be recognized in the last 15 and not more than 20 years. And it's because most clinicians usually focus on having couples who come to clinic to try and get a baby, to get pregnant. And it is that reproductive focus that takes away the attention from mental health. And I think it's Professor Boivin in the early 2000s who dedicated a lot of her efforts in understanding mental health consequences of subfertility. And the numbers are actually daunting. When you look at the general population of couples who come through fertility and assess their mental health, you may actually be surprised that they could be slightly higher in a lot of places than the study that is being quoted locally. But what is more important is always to remember that fertility is not a female problem, and we are trying to also encourage gynecologists and other doctors who see patients struggling with fertility to always encourage them to bring along their male partners as soon as possible in the journey for evaluation and treatment. And we know, depending on the setup, the cause of the problem could be 50-50. And the consequences are well known, apart from the societal expectations and all the other bits that couples go through. The emotional turmoil is extensive, and we know many individuals who then get very withdrawn. They will tell you, I can't go to any social functions anymore because my friends will be turning up with children and I haven't got anyone to come along with. And they can't even go shopping where there are children playing around because they feel something is horribly wrong with them. And I think apart from, that mental, psychological struggle, there are also internal struggles within themselves. And we also see other bits that may come as a consequence of that, which may include even violence. And so it is a big issue that has to be looked at holistically. And of course, because we are specialists and every time we continue to subspecialize, it calls for collaboration with other colleagues in areas that you feel your patient will benefit, because we are increasingly in a society where a focus is on a particular area of specialty, and then it leaves our patients extremely vulnerable. So working within such networks is likely to improve the outcomes. And it's not always after unsuccessful treatment that then you want to think about your patient seeing a psychologist or a mental health expert. It is right from the beginning, when they start the journey, that you need to engage them. Thank you.
Thank you very much, Dr. Muteshi. Once again, every time we listen to you, get very, very interesting insights around this particular area on reproductive health. Something that I need to announce. So as the conversation progresses, please feel free to put in your question on the chat box. And there are 2 emails that will be shared on the chat box in the next couple of seconds. For anyone who is affiliated with KMPDC, feel free to write us an email and you'll be able to share CPD points with you in the course of the week. So now, before I come back to you, Dr. Muteshi, I also need to introduce our other panelist, Dr. Caroline Vundi, who is a consultant psychiatrist. Her work champions gender-sensitive care across mental health and reproductive health services. With her nuanced lens and compassionate approach, Dr. Vundi will help us to reflect how infertility uniquely affects women's emotional lives and the dynamics within the couples. So I'd like to introduce you, Dr. Vundi, just first of all to hear your insights about this before then we can move into the Q&A section. Dr. Vundi? Dr. Vundi, are you there? Okay, so probably as we wait up for her, let me poke at Dr. Muteshi a little bit, because you're the one who was just on screen a couple of seconds ago. Yeah. If you may, can you please just help us have a bit of understanding around how this matter on reproductive health and infertility affects people across different age ranges?
Yeah, so I think if you look at the general fertility or subfertile population, we know as couples or particularly ladies get older, the chance of getting pregnant diminishes. And that is mostly due to biological factors, because the oocytes or the egg numbers decrease and the quality also diminishes. But the expectations from society will actually increase as you get older, because they think now you're settled down, you have a good job, we need to see the children. So you're having to face these twin dilemma that the doctors may be telling you your chances of getting pregnant are decreased, and there is a lot of pressure, from your peers. And of course, one of the things that makes worse the mental health consequences of subfertility is when you feel a process that is so natural and easy is not producing the results. And mostly you wouldn't want to think there could be an issue that the doctors can resolve. Immediately couples try to point fingers at each other and say, oh yeah, I think I'm not getting children, but I suspect I'm the problem because previously I've had a baby, or my partner's had a baby, and so there isn't any issue with them. And so as you notice, younger individuals are probably less likely to face this bigger issue. But I guess the numbers might be lower because when you are younger, you are probably not yet settled down, or the expectation is not as high as when you get older. But as you get older, then there's other bits to fight against, especially the biological clock. It is also important to mention that we have a big issue of what we call secondary subfertility. And secondary subfertility essentially means these are couples who have had a child or children before, and they would like to expand their family, and they can't just do it. And they can't wrap their heads around the fact that there could be a problem when previously it was easier for them to conceive. And, it is also very easy to forget them because everybody might have the notion that there should not be an issue. And actually, they probably form a bigger chunk of the patients we see in the fertility clinics who are trying to get pregnant. The other issue that may affect older more couples more than younger ones is when they have to contend with options. And if we think the chance of conceiving is not as easy with your own oocytes as compared to using a donor egg, then it opens up a Pandora's box for other things to be considered. And, there's biological relatedness, there is issues related to disclosure to the baby when the baby is born, whether that, you like them to know about their donor. Are donors related to you? Are they anonymous donors? So there are a lot of other things that they have to think about. And it is both male and female donor gametes. So it's not just oocytes alone. So definitely the problem gets worse as one gets older, and because they also are rushing to beat the clock.
Thank you, Dr. Muteshi. We're having a bit of a technical hitch, and that's why we're not able to get Dr. Vundi in the moment, but she will be joining us. While we still have you right here, are there critical moments or critical windows where mental health intervention would be most effective, or would it be at any given time that then, it would be effective? Because I would imagine that someone who's been struggling with this for a long time would, benefit, but then someone who probably is just starting out the journey, for them it would be more preventative measure. I think that's the lay approach in all of this. So are there critical times that would be most effective, or would it be at the earliest possible?
I think it's essential that one is always alert to the fact that, couples or patients coming through for fertility assessment and treatment might be struggling with mental health problems. So deliberately trying to ask for specific leads would be useful. There are also other times, especially if decisions have to be made with certain diagnostic tests, you may want to, ask a partner whose sperm sample, for example, shows no cells. So you want them to go through particular tests and what the implications of those are. And at that point in the diagnostic journey, they will still need psychological support. Decision regarding moving on to treatments can also be difficult, and they are quite complex, especially where couples have to choose between various options. And unfortunately, the treatments we have for fertility treatments are not always successful in 100% of cases. So you're looking at numbers, and the prognosis gets worse as they get older, or they've been trying for longer. So this reality has to be put on the table sooner. And after some treatments, even when it's been successful, you don't assume that a couple who have had a pregnancy from a fertility treatment, they're completely off the hook. We know from literature quite a number of couples who get pregnant and they come back saying, I don't think I'm ready to carry on with this pregnancy. And they actually are asking to be referred for termination in places where that can be done. And so you need to always be aware that can pop up. There are also other issues related to fertility, which may not look very straightforward. For example, you might have couples with genetic conditions. In this part of the world, sickle cell anemia is very common. So whereas they may ordinarily be able to get pregnant easily, but then there is the big risk that a baby could be affected. So those ones also need some very special psychological management. Yeah, thank you.
Wow, that's a lot of insight. Thank you very much, Dr. Muteshi. And now I want to take us back to Dr. Janisha. So there's a question here from Dr. Wairoto, which reads, what interventions were carried out for participants who screened positively for depression?
Thank you so much for the question. So as the study was done in Kenyatta National Hospital, all patients that were positive or who screened positive for the depression, we referred them to our KNH psychiatry department for further management, both psychological and if it was severe, as well as the psychiatric.
Mm-hmm. Now, while we still have you there, I know this is something that Dr. Muteshi has also spoken about, but in your study sample, age didn't seem to have a lot of statistical significance. Would you please tell us whether, that's something that, in practice you have seen as something that pops up, that age becomes something that is significant, that different ages respond differently to this situation?
As for me, as you mentioned, I was really not looking at the socio-demographic factors in depth, but I did not find any statistical significance in mental health outcomes across the age groups. However, clinically, there's this thing where people say their biological clock is ticking. As Dr. Muteshi said, the older you get, the more pressure you have for trying for a child and all that. So clinically, I do see that there is some differences in age where the older they get, the more psychological burden they take because of the pressure of the biological clock ticking. Thank you.
Okay. Now we finally have Dr. Vundi back, and I had introduced her to you guys. So again, I'm so sorry, Dr. Vundi, for experiencing the technical glitch that you're having this morning, but we'd like to hear some of your insights about this particular subject matter. Dr. Vundi?
Thank you, Thank you, Zawadi. I hope I'm audible.
Yes, you are.
All right. So I just wanted to say that a lot has been said. So I'm just adding and building on to the one study that Juliet did and also Dr. Amjeti's insights. For me, one thing that has been coming up in my practice as I work with women who are dealing with infertility is something I would call when the dream comes true, but it's still hard. So a lot of women who battle infertility, when they eventually get pregnant, go through some mental health challenges that I wanted to share. So after months of trying to conceive and after months of invasive treatments, financial strain, many couples eventually get to the point of burning out, such that eventually when they do get pregnant and the long-awaited baby comes, instead of joy, or in addition to the joy, there's emotional numbness, panic, guilt, disconnection, especially if there have been previous losses. There's this feeling of, yes, a baby is here, but what about the other babies I lost, for instance? So there are some studies that bring this out. For instance, there's a study by Choi et al., an old study of 2012, but still relevant. It found that women with a history of infertility reported higher depressive symptoms postpartum than those who conceived spontaneously, even after adjusting for confounders. Another study I thought to highlight is Fisher et al. Of 2015. Who noted that despite the baby being wanted, there is emotional exhaustion from infertility and the stress of new motherhood, which is higher than the general population. The last I wanted to highlight is a study by McMahon, a 2013 study that explored the paradox of joy and grief. So, where IVF mothers expressed profound love, but also high anxiety and unresolved grief from past losses. To wrap this up, because I'm just about to jump on a flight, I wanted to just give to share an experience of a patient that I have who, after 10 years of infertility, eventually conceived spontaneously, not out of IVF. So what she presented to me with was a feeling of unpreparedness. She had already accepted the fact that she might never be a mother. The husband had also gotten to that point, and they were very okay with the fact that they would never have children. And then 10 years later, they have a child and they feel very unprepared. And the mother even confessed to saying she feels resentful that now her time has been taken away. They no longer can have the private time they had as a couple. They can't just spontaneously go on holidays. So there was a bit of resentment towards the child. So as we work with women who are dealing with infertility, let's walk the journey with them even after they end up having these children, because there are a lot of mental challenges that await them in the end of their journey. Thank you so much.
Thank you very, very much, Dr. Vundi. And thank you again for at least being here with us, even, with you being in transit. I want to ask a question to you, Dr. Vundi, before we lose you. How do you
No
manage the
problem.
couple dynamics in these particular circumstances? Because culturally, when there is infertility, culturally, we will pretty much just assume and attribute it to the fact that it is the lady who may be unable to bear children. And that, of course, brings a lot of couple dynamics, especially when the couple by themselves are going through the journey of fertility care, and they probably know where the problem is, but the people around them keep saying things and doing things that are very emotionally triggering.
All right, thanks for that question. Cultural context is very important. especially in the African context, motherhood is seen as the ultimate marker of womanhood, and fatherhood is seen as the ultimate marker of manhood. So, this is how I usually manage. Is first of all, by when you have the couple in front of you, it's very important to get down to the basics and speak to them about why really do you want to have a child. um, and when you personalize it, you find most couples, they leave behind what their mother-in-law wants, what their father-in-law wants, and they say that actually I want a child because of ABCD. So personalizing the experience for them and just bringing it down to that is something that I recommend. Couples therapy is something also I highly recommend, because sometimes you find that couples don't know how to protect each other when the community or relatives are speaking into their relationship and telling them what they want from them. But one thing I also do with patients is education. So I like to educate specifically the men in these dynamics, because for them, they feel silent. They feel like this is just a woman's experience. I should just be quiet and pay for the IVF. I'm not expected to have any depression or anxiety. So a lot of education for them. And lastly, I also encourage them to get into safe spaces. So there are a lot of infertility groups, so that they can see that it's not an isolating experience. There are other people going through the same thing. And these communities really bring a sense of they really dismantle stigma and fear and shame.
Thank you very much, Dr. Vundi. I think as you bring on that whole component of supporting men, now I'd like to pose this same question to Dr. Muteshi, but in a different form. How do we, like in real time, how are men supported, especially in regards to, like the context or the concept of masculinity and identity when they are struggling with fertility and, like infertility issues?
Yeah, that's a very interesting and I think very important question, Zawadi. There are various aspects to it. One is there's a general man who comes through because they can't have a baby, and maybe the problem identified is related to, let's say, female factors like tubal blockage, and everything is absolutely fine with him. They've got their own psychological challenges, which are addressed in the manner that we have discussed here. But then there is also the man who comes through, and there are maybe male factor subfertility issues. And we now know that if there is declining sperm parameters, especially what we call severe low sperm counts to zero sperm counts, which may also be associated with additional hormonal problems, then the issues tend to go beyond just the fertility concerns. And there is enough data to suggest these are men who are at higher risk of additional long-term health problems, which may also include a risk of premature death. And of course, you have to come down to their diagnosis and say to them, your sperm count shows that we have very low numbers, or there is zero numbers. So what is the implication of it? We need to do additional tests to assess your general wellness. And it is not always very easy for someone to conceptualize the consequences of that, because a lot of men believe because they're able to have intercourse, everything is okay. And in fact, most of them will not immediately agree to doing a test because they believe if I'm able to have intercourse, then I'm fine. Yeah, so they need a bit more attention, and breaking it down to what it means and also what it could mean for the future.
Okay, that's very, very interesting. Very, very interesting. Interesting input over there. Quite a number of things that I was not cognizant of. Now, Dr. Janisha, in your study, you found that there was a discrepancy around, or rather, there was what's it called, significance association between rural residency and the quality of life. Would you like to tell us a little bit more about that so that we can just have an understanding of this particular very interesting observation that you made? Dr. Juliet? Well, as we find her, there's a question here that reads, how do we support the ones with unexplained infertility issues, given that they have no reason to heal or focus on? So I think this question would be better addressed by Dr. Charles. How do we support the ones that have unexplained infertility difficulties?
Yes, so they are not any less likely to have psychological problems than those with a determined diagnosis. But they also may be considered to be better prognosis for fertility than if there is a definite cause. And so we know if all tests come back normal, then you need to consider the duration of trying and the age of the female partner, particularly. So if they are younger than 37, and it's less than 2 years of trying, it's worth encouraging them that if they keep trying on a regular basis, the chance of conceiving is improved. We do know that a lot of people who are trying to get a baby then go into particular routines and practices that may be considered counterintuitive. For instance, they may not have intercourse and only want to do so when they think they are in the most fertile window. This is quite disruptive, and biologically it may decrease the chances. So when you look at them and say, yeah, this is unexplained subfertility, a given time there is still some chance that and the numbers are usually as high as 85 to 90% within 2 years of trying, then they may feel a bit more relaxed and they could be lucky. If it's taken longer than 3 years, then they may need to be routed into assisted conception.
Okay. Dr. Vundi, I don't know whether you're still here, as I still try to locate Dr. Janisha. Maybe you can help us have an understanding of why it would be that people within the rural setting would have a lower quality of life vis-a-vis those in urban, peri-urban, and other forms of settings. Dr. Vundi? Oh, goodness. Okay. I seem to have lost her too. So, Dr. Charles.
Hi.
Hi. Oh, thank God, here you are.
I don't know how the sound is. You let me know if I'm audible.
Yes, you are audible.
All right. For me, what I would comment about that dynamic of why the quality of life is lower in rural setups, I believe that in the African context, the culture is still very strongly expressed in rural areas, whereas in urban areas we have adopted more urbanized approaches. For instance, you might find in an urban context, being child-free is something that women are openly talking about, but in the rural areas, still very rooted in our African culture. But also, I believe that why the quality of life lower is that in some cultures, some a family's status or the wealth of a family is determined by how many children you have, because children are considered as labor. So in that context, you find that a woman who does not have children is seen as she's lowering the status of her family. And in that case, she does not have enough people maybe to till the land, or she doesn't have any form of people to assist in building the wealth of the family. So that's what I have observed. And I also believe that when it comes to infertility in the rural setup, also seen as an omen. So those the women are usually ostracized and treated as outcasts. So their quality of life will be lower. They will not be invited to social spaces, or if they do, they're treated basically as outcasts. Thank you.
Thank you very much, Dr. Vundi. There's a very burning question that has been sent, and this one I think we're going to have Dr. Charles and Dr. Vundi help us just navigate through. So the question reads, what are the systemic gaps in how mental health approaches fertility care in Kenya? I think that's a very loaded question. What are your thoughts on this, Dr. Charles?
Yeah, as you say, it's a very loaded question.
Yes,
I
it's a
agree.
very loaded
Partly,
question.
yeah, part of the issue is, we don't have a health policy or a guiding document that defines how we probably approach fertility and least mental health. In other jurisdictions, it's very easy for physicians to know, even at GP level, when you are seeing a couple of patients who have some fertility issues, that they do route you into pathways of care that may include mental health support. So that's one issue. Second issue is, the capacity. We probably do not have enough mental health practitioners who are able to then look after patients who have fertility related problems. And one other issue is it's also a specialized area of practice. And so if we send a patient with a mental health issue related to fertility, it's very likely that a general counselor may be able to deal with them. But sometimes, you need that specialization, that you have focus. For instance, I know counselors who deal with trauma, for example. It could be different type of trauma. So we do understand that if you have ability to specialize, you will be better off. But we do have capacity issues here. I don't have data, but anecdotally, a lot of patients, when are referred to mental health practitioners, you have to tell them why they need to be seeing them, because there is some form of stigma, or everyone thinks if you're going to see a psychiatrist or a counselor, and then you're mentally unwell. So they may not buy in. So we need to educate them and let them understand that it's the burden that we are trying to lessen, and not label them to have a diagnosis or to be mentally unwell, because everyone thinks they have the picture of this person who is unkempt and running around the streets, who requires to see a psychiatrist. So we've got all those bits that require perhaps to address.
Okay. Thank you very much, Dr. Muteshi. A lot of food for thought for all of the mental health practitioners that you have in this room. Dr. Vundi, do you have any additions? Because I have yet another very loaded question for Dr. Muteshi.
No, I believe he's addressed it. Perhaps the only other systemic gap would be cost. But I think that's self-explanatory. Infertility and mental health support, it will be quite pricey.
Mm. Okay. It is, like very, very understandable. So when people shy away from seeing mental health practitioners, because fertility in itself is a very touchy subject, mental health is equally a relatively touchy subject. So it makes sense as to, like a lot of the worries that one may have when suggested to see a mental health practitioner. Now, there's a very, very loaded question that I need to ask you, Dr. Muteshi. And this question reads, should ladies above 34 not previously diagnosed with infertility, not married, potentially not having sex, be concerned about their fertility? And if so, which test should one do just to know?
Yeah, so you may notice that fertility is a function of trying to get pregnant. So, and if you haven't tried, then you don't know if you'll easily get pregnant if you tried to. And so you don't have to worry. But flipping it the other way, we also know age-related fertility is an issue that comes up, and people may take long before they are settled. And by the time they do so, time's passed. So in such instances, it might be recommended, to consider speaking with your gynecologist or reproductive endocrinologist to assess particularly egg numbers, and with a view that if there is no immediate need, and immediate need would mean within 1 to 2 years of trying to get a baby, one could consider if they are able to freeze their eggs for future use. And if you put your eggs on ice, then it lessens the burden. It's not 100% surety that you will get a baby when you want to, but it gives you better chances that in case you needed to have IVF, your odds are better if your eggs are frozen earlier than if you try to do IVF 5 years later.
Okay. Thank you so much, Dr. Charles, for that. Now, Dr. Janisha, I hope we have you back with us, because I need to bring us back to where we all began with your very insightful study. And we have a question on that, which is, what lessons can be drawn from your findings to guide the development of evidence-based mental health policies around mental health and reproductive health care?
All right, thank you so much, Zawadi, for the very excellent question. So studies, and also my study, reinforces that infertility is just not a biological or a medical issue. It significantly impacts psychological well-being. So policies must mandate routine mental health screening like depression, anxiety, or even distress in fertility clinics, both in the public and private sector. Another thing of note is gender-sensitive mental health interventions are very critical. So policies should integrate gender-responsive psychosocial care, including the counseling and education tailored for both men and women. Also, men engagement must be normalized and incentivized. As mentioned earlier, cultural and social norms discourage men from participating in infertility evaluation and treatment. So policies must include public awareness campaigns and clinic-based interventions that encourage male involvement, reducing stigma and emphasize the shared responsibility in fertility cases. And finally, of course, more local studies need to be done and design culturally relevant and community-sensitive interventions. Thank you so much.
Thank you very much, Dr. Janisha, Dr. Charles, and Dr. Vundi, once again for taking us through a very, very engaging conversation. Now I'd like to invite Dr. Frank Njenga to give us his input around the conversation that you're just, working through this morning. Dr. Njenga?
Thank you, Zawadi. I have nothing useful to add. I have only 1 minute in which to not say anything. Just two quick things. The first one that obviously this is a very important, relevant, and appropriate conversation that has taken place at a very, very, very high level. I saw a little, not a little, I saw a comment by Dr. Moshero saying how much he appreciates the fact that this is a multidisciplinary approach. And I think this is what we should encourage in this forum, which I think is very important. Just one other thing I wanted to say is that the WHO is encouraging us more and more about bringing in people in conversations such as this one who have lived experiences. And if I score you at 98%, is because if you had brought a person with lived experience to just give us their perspective on this one, perhaps even a couple, each to demonstrate the points that have been made in excellent fashion by all the three speakers who have been with us, that would have given you 100%. So today, you only managed 98%. Thank you very much and have a good day.
Thank you very much, Dr. Njenga. We have taken that recommendation with a lot of seriously, and we endeavor to make your CME experiences to 100% optimization. Now, I would like to conclude today's session because we are out of time. But as we leave this morning, I'd like us to remember that behind every fertility statistic is a human story, often invisible, sometimes inaudible, but always deserving of empathy and understanding, as has been demonstrated numerously and very loudly by our abled panelists. I would like to thank Dr. Juliet once again. I'd like to thank Dr. Charles, as well as Dr. Caroline for joining us this morning and taking us through this very, very timely yet highly underspoken about reality of life. But with these very, very many remarks, I would like to thank you for being part of Entangled Emotions, and I'd like to welcome you once again 2 weeks from today, where now we will be having our great debate series. So anyone who is still affiliated with the KMPDC, like it has not changed between the time we began and where we are right now, and it will not change, a few days, weeks, months moving forward. Feel free to write to us on the email that has been provided in the chat box so that we can organize for you to get CPD points. Asanteni sana and have yourselves a lovely, lovely day.